We want to thank you very much for joining us and agreeing to talk about your experiences. Dr. Condos, why don't you tell us briefly about when you met Mr. Apicella?
Sure. It's not uncommon for patients with interstitial lung diseases like idiopathic pulmonary fibrosis to be referred to me for evaluation, and that's exactly what happened in Rich's case. He was being seen by one of my colleagues and actually had an open lung biopsy for an abnormal CAT scan that he had and some symptoms, and his diagnosis at the time of the biopsy was idiopathic pulmonary fibrosis, and he was referred to me for further evaluation and workup. And that was actually almost 7 years ago. It was actually in 2010.
So, Mr. Apicella, I'd like to take you back to the beginning, if we could, and tell us what you began to experience that led you to see a doctor and discover that this was a problem that you had.
Well, actually, I didn't have any symptoms. I had an X-ray. I had to get a CAT scan because I had a pain in my side. And they took the CAT scan. There was nothing there. It had no bearing on it. But they said they found something in my lungs. And so I was recommended to see a Dr. Garofano. And she said, well, whatever it is, we don't know what it is, but it shouldn't be there. So the only way we can really tell is if you get a biopsy. And I wasn't in favor of getting a biopsy, so I didn't have any symptoms. I had no idea what was going on. And so I kind of put it on the back shelf. Mm-hmm. And a couple of years later, I was a four-wall handball player at the New York Athletic Club, and I started slowing down. I started running out of breath, and I wasn't sure what it was. So I finally went back, and she said, well, the only way we're going to figure this out is if you get a biopsy. And in 2010, I had the biopsy.
When you first got the news about the CAT scan and the findings on the CAT scan, what were your thoughts?
Nothing. I really didn't. I kind of discounted it. Mm-hmm. They didn't know what it was. It wasn't affecting me, so I had no concerns.
Mm-hmm. And what was your understanding about the biopsy, up until that point? What did you understand would be entailed, and what were the risks, the potential benefits?
I had a brother who had a biopsy. I don't know if it was the same type of biopsy that I had, but he had a lung biopsy. I think he had pleurisy. Mm-hmm. And he said it was the worst thing he ever went through. It hurt like hell. Mm-hmm. So in the back of my mind, I wasn't going through that.
That was enough.
Yeah, that was fine with me.
Did the doctor hear that story from you during the earlier conversations, or was that something that you knew and kept to yourself?
Yeah, I did. I don't think I explained it to her the way. Mm-hmm. I should have.
Well, or she should have asked.
Why don't you want to go through a biopsy?
Yeah.
Could be.
Or just what your understanding was of what the biopsy would entail.
I didn't ask her. She didn't ask me. I didn't know what it was all about. He said they put a needle in your ribs and took a chunk of your lungs. Mm-hmm. So I wasn't going there.
After the biopsy, there was a visit when you were going to come back to learn the results.
Yes, and when I did come back, she said, you have pulmonary fibrosis, which meant nothing to me. I had no idea what pulmonary fibrosis was. She says, but I want you to see my colleague, Dr. Condos, and because she's a specialist in that field, and it's more than I can help you with. So she's going to take over from here.
So you mentioned that when the doctor said to you, you have pulmonary fibrosis. You had no idea what that meant.
Could have been the measles, for all I know.
So what went through your mind at that moment, if you can recollect in the conversation?
Just the fact that I had something wrong with my lungs, and but I didn't know. I mean, I didn't know what was going to. I mean, even when Dr. Condos told me what I had and what I was going to go through, I didn't believe her. Mm-hmm. Because I was feeling nothing. I had no real symptoms.
Right. Did you have any questions when the other doctor presented this diagnosis? Did you feel like asking? What were your thoughts at that moment?
What is pulmonary fibrosis? She said it was a scarring of the lungs, and which again meant nothing to me.
Did you have a mental picture? Did you imagine something in your mind when she said that?
Not really. Really, honestly. I said, what causes it? And she said, well, we don't know. We're not sure what causes it. And I'm saying to myself, well, how could you come up with this? How did I get it?
Dr. Condos, what do you remember about the first encounter and the beginning of your working together?
Yeah, I think Rich's case is very typical for patients with pulmonary fibrosis. And there's two kinds of cases. Ones that present with symptoms, and so that makes it a little bit easier because patients are usually expecting that there's some problem, and that's why they're having a symptom. And then there's a whole new group of patients, and we're seeing more and more of them, where the actual abnormality is identified before they have any symptoms on a CAT scan. And so nowadays we do a lot of screening CAT scans looking for lung cancer in smokers. And smoking is one of the risk factors for idiopathic pulmonary fibrosis. So a lot of patients will get CAT scans for other reasons and then will be found to have these little abnormalities.
And when you did arrive in Dr. Condos's office, what do you recall about that conversation?
That she told me I had pulmonary fibrosis and that the average span was 3 to 5 years. Now that got my attention.
Can you say more about that?
Yeah. I was kind of, I won't say befuddled, but it didn't make any sense to me. I didn't feel any problems. I mean, there was no symptoms. And yet, she's saying that, you got 3 to 5 years, typically, is the average for a person with pulmonary fibrosis. So that affected me a little bit, and I think I got sicker just because she told me that. And then I started feeling, it started working on my mind. She also told me that fibrosis comes in levels. And what would happen is that I would get a cold, and it would go to my lungs, and I would be sick for a week, and we'd have to go on antibiotics and prednisone, and I would never come back from it. I would just never recover completely from that cold, and it just kept happening. And towards the end, I mean, the last drop was in the last, let's say, 6 months, where I went from being on 3. Actually, in 2013, she suggested that I go on oxygen because my levels kept dropping down into the 80s.
Right.
Well, in the last month or 6 months, I mean, my levels would start dropping into the 70s. So it was all a saturation, that I kept losing my saturation.
How did you come to understand the nature of the disease? If somebody had asked you, I hear you have idiopathic pulmonary fibrosis.
Right.
What is that?
I would tell them it was a scarring of the lungs. Now, we don't know what's in there, which is causing the scarring, but eventually the scars are going to take over all the capacity of the lung.
Uh-huh.
I mean, that's the way I understood it.
Yeah, and did you have an image of this scarring, or?
Other than the scar that you get on your arm or your leg whenever it heals, there's a scar.
Right.
And I assumed that was covering all the sacs of the lung.
So like on the outside of the lung?
No,
or
inside the lung. Yeah.
So Dr. Condos, the very beginning, what was your experience working with Mr. Apicella and trying to help him understand what was going on and getting things going?
So I think that initially, he's absolutely correct, that he didn't really understand some of the implications of what was happening. That this was a progressive lung disease, that this was eventually going to kill him, and that there were certain things that we could do to try to keep that from happening, or at least push it off for as long as possible. And part of that included exercise, which initially he was doing very well with. He continued to play paddleball, he felt good, but then at some point that fell off. He started maybe thinking about it too much, was a little more short of breath, and was not exercising as much as he should. We talked a little bit about treating acid reflux, which is one of the things that we do in patients with idiopathic pulmonary fibrosis. We looked to see if there was any sleep apnea or any other issues going on. There was always a little bit of a weight issue that we were struggling with, and that was something that we kept coming back to, because that is something that not only makes breathing harder, but it also makes it more difficult to eventually get a lung transplant. So that was an area that was constantly, we were talking about all the time. Exercise and weight loss were sort of the focuses of our evaluations over the years.
How do you remember that period of time and the suggestions that Dr. Condos had for you?
Well, Dr. Condos suggested that I get into the NYU rehab program, and so that helped a lot. As far as the weight goes, I never thought I was heavy until we applied to Columbia, and they sent me a letter saying that we will not even talk to you because your weight index is around 36 or 38, I think it was at the time, and that you need to be down to an index of at least 32 or something like that. So I had to lose 45 pounds.
Tell us about getting that letter.
It was devastating, because eventually when I realized that I needed to get a lung transplant, that kind of opens up your eyes a little bit, and saying that that's the end game, is either getting a lung transplant or not, and if not, is the alternative is not good. So when they said I have to lose the weight, somebody suggested to me that there's an NYU weight loss program. They put me on a diet. It's called New Direction, and it was shakes and powdered soups and whatnot. But anyhow, within 6 months, I had lost the weight, and so we reapplied back to Columbia, and they finally called me in, and it's a heck of a process to go ahead and get on the list. I think we had to go through some 25 tests.
So prior to having your eyes open about the need for a lung transplant, and then receiving the letter where the necessity of losing weight, was brought home to you, you were aware of this issue for a period of time.
Of the weight problem?
Yeah.
Yes.
Yeah.
Dr. Condos always said to me, "How's your weight? How's your weight? How's your weight?"
And what was your experience here during those conversations?
Working on it, boss. Working on it, boss.
And
working on it, boss.
And what did that mean?
Nothing. Nothing. It wasn't until I got that letter that it was really eye-opening.
Right, right. And how did you feel about, the fact that it took you so long to get to that point?
Good question. Good question. I never felt like I was, because I was always in good condition, not great shape, but I could still get in my 44 pants or whatever it was at the time. It really, I didn't have the willpower to do it until you see that you either do this, pal, or it's curtains.
So what was your experience with the earlier phase where you knew what might lie in the future, but it was difficult for Richard to appreciate that and to be motivated?
I think for me, it's always an issue with patients trying to educate them about weight loss, and it's also very difficult for patients who are limited to lose weight, because they can curb their calories, but they're not exercising as much because they're short of breath, because they can't do the things they used to do. And so it becomes a vicious cycle. It's not only that they're consuming more calories than they're burning, it's that they're not burning as many calories as they used to. And so it's a very, very difficult situation. And it's really hard because patients get set in their ways. They don't, they don't want to change the way things are. And I have to be honest that with Rich, the letter with that documentation of the BMI being less than 30 required for evaluation for transplant is really the moment that turned the page. Because, seeing that in writing and saying that, this opportunity is going to be taken away because you can't get this weight off, was what actually motivated him to get it done.
Yeah, exactly.
At some point, you started using oxygen.
Yes. When the Dr. Kondo suggested that I get a
Pulse oximeter.
pulse oximeter, or whatever it is, and you know, at that point, and she said, you can't be under 90. You don't want to go under 90. And back then, I was like 90. I'd be 89, 88. When I got up and moved, so I think it was 2013. She said, I'm gonna write you a prescription, because I was getting down in the middle 80s, and so she wrote a prescription. The gentleman came to my house. He said, I want you to walk up this flight of stairs, and when I got to the top, I was in the 70s. So he said, "Ooh," wrote it down, and I was on oxygen ever since.
So, what were your thoughts as Mr. Apicella progressed about using oxygen and his treatment?
Yeah, so we like for patients to stay as active as possible. We want them to maintain their quality of life, and part of that is continuing to exercise. So the last thing that we want is for patients to be short of breath and sitting at home. And so one of the ways that we try to mobilize patients is to provide supplemental oxygen when they need it, so they can get out and about and maintain an active life. And that's a difficult thing to get patients to accept, because it's the first indication to them that there's really something wrong. Now I can't go outside without my oxygen. And there are lots of patients who will wear it at home, and then as soon as you tell them to come outside, they won't, because of vanity, because they don't want others to perceive them as being ill. And that's usually the hardest hurdle to get over, because it's really an acceptance by the patient that they actually have an illness that's progressive and that will most likely cause them not to breathe ultimately.
I mean, I wouldn't even use the oxygen when I was in rehab.
Right.
And because exactly what Dr. Kondo said. Yeah, it was just like, I'm not wearing oxygen. I don't need oxygen. But I did need it. And actually, one of the other instructors came over. I was like 88 or 87, and she said, well, you need to be on oxygen, because you're never going to be able to increase your activity unless you're on oxygen. So they made sure that I took the oxygen, because I was just using it to sleep at night. So they made sure that I got on oxygen, and I was able to increase my activity.
So you were going by how you were feeling and your ability to function.
Exactly right, rather than looking at the meter.
Yeah. Did you carry that with you, or
not in the beginning? No, I would forget it all the time. I would leave it at home.
Tell us about forgetting.
Yeah, well, it wasn't part of me, so I didn't realize it, and I didn't realize how important it was that you don't, let your saturation drop, because now you're causing all kinds of havoc.
Now, Dr. Kondos had been talking to you about the consequence of letting your saturation go below 90, even before you had symptoms. Do you want to talk a little bit about the task of helping patients accept the need for oxygen and use it appropriately?
Yeah, it's very difficult. It's certainly much easier when patients are symptomatic. As terrible as that sounds, if a patient is short of breath and they're gasping, it's much easier to get them to agree to wear oxygen. When a patient doesn't sense that shortness of breath, it becomes much more difficult, because they don't feel like they need it. There's a stigma associated with wearing it. And it's very hard to get patients to understand a theoretical advantage to not letting your oxygen saturation go down, which is to prevent the development of pulmonary hypertension, which used to be, although it's not anymore, it used to be a contraindication to lung transplant. But when a patient doesn't really have those symptoms, telling them, you know what, check the number, and if the number's low, you need the oxygen, that's a different altogether idea.
What do you recall about those conversations?
Yes, I did. And not until, even when it got down in the 80s, they said it'd be all right, it's going to come right back. And we'd just rest a second and would come back up again. So now it's like, well, how long can I last? Well, it's down in the low 80s or in the middle 80s. You know, before am I going to collapse on the street? But no, I didn't think so.
What do you recall about the idea of pulmonary hypertension?
I had no concept of what pulmonary hypertension was. You know, I didn't know what you were supposed to feel. I didn't know what kind of damage it was going to do. I mean, I found out later on.
So what's your understanding about it now?
Well, that it's the pressure between, you have two different blood pressures. One is the pressure between your lung and your heart, and that if you have pulmonary hypertension, it could be beating your heart up.
So Rich, I'd like to take you back in your medical history to when you had that pulmonary embolism, the blood clot to your lungs.
Right.
Do you remember when that was?
Absolutely. We were out, my daughter and I were out at the Hampton Film Festival, and we were getting ready to leave, and I came down the stairs and into the car, and when I sat in the car, I was gasping for breath. I mean, the whole weekend was a little bit tougher than usual. But when I got in the car, I could not breathe, and I said, stop the car, I got to get out, I got to get out. And I got out of the car, and I couldn't believe that I couldn't breathe. And I had no idea what was going on. You said, okay, go to the emergency room at NYU. And I did, and they put me through a CAT scan, and I'll never forget this story. I was sitting on not the gurney, but in that little room there, and the doctor came back and he said, I know why you can't breathe. He says, you have a saddle embolism.
Right.
I said, what's a saddle embolism? Actually, my brother had a saddle embolism. And he said, the blood clot is so big it's covering both your lungs. And I said, you know what, doc, that's actually pretty good news. He said, I don't understand. I said, I thought it was the fibrosis. And if that was the case, I'd really be in serious trouble, but I know you can fix this, and they did.
So tell me how that made you feel. That was your first episode of really having the breath taken away from you by a medical condition.
Yes.
How did that feel, and how did that make you move forward from that?
Well, I mean, it felt like I was drowning,
Right.
and that I wasn't going to, that I was going to die. I mean, there is no feeling in the world when you cannot catch your breath. I mean, I don't care what it is. And I see these people out there smoking all the time that they take their lungs for granted. And not until you cannot take a breath do you understand what that's like. Yeah. And so it was really traumatic for me.
Yeah, and I want you to think back at how that affected how you moved forward from there.
Well, that was like the key starting point, is that I never wanted to feel like that again. And when I did get back, then I think we really got serious on the diet. We got serious on working out, and I knew I was in trouble.
Yeah.
I knew I was in real trouble.
So I think, again, you know, having a symptom going along with this name that they gave you, this pulmonary fibrosis, was, you know, something that pushed you in the direction of trying to be more compliant with what we were talking about the weight loss, about, you know, making sure that the oxygen levels are good, about exercising. I think that the fact that you had that sort of life-threatening episode is really what turned the tide in terms of your ability to understand of what was you were to be expecting moving forward, and what you could do to kind of change things. And I think for me, it's the pulmonary embolism that kind of changed your attitude towards this disease.
Exactly.
Because I think when you got that taste of what it's like not to breathe, it made you take the dieting a little bit more seriously, the need for oxygen a little bit more seriously. And so we moved forward much faster in terms of your progress towards the transplant and getting better than we had before that pulmonary embolism.
Absolutely.
And so I understand why you would think that the pulmonary embolism really doesn't have anything to do with this, because it's probably related to this genetic abnormality that you share with your brother. But that experience, I think, at least from the caretaker's perspective, really changed how you looked at this disease.
Well, I tell you what, it's a life-altering experience, and was something that I didn't want to go through again.
Right.
No question about it.
I'm kind of struck by the fact that you had heard that pulmonary fibrosis was going to lead to this condition of not being able to breathe.
Oh, yes, yes.
But, so that was a fact that you knew, but after the embolus, it became something that you believed.
Well, once you cannot get your breath, and if I can, correlate that with what's going to happen to me with the fibrosis, yeah, there's no question about it. I mean, that set a new bar. And that I didn't want to go through that. I didn't want to go back to that again. That was for certain. And the thought that this is going to happen at the end of this flight of stairs, that's what it's going to be like. Now I was really getting frightened. That opened my eyes and said, we can't do this. I can't handle this, because it was scary.
It's clear that once you had the personal experience of really being short of breath, that you saw the need to do the things that had to happen. Just wondering if, knowing what you know now, whether there would have been anything, you would have said to yourself prior to that would have changed your perception that you needed to do these things before you felt the symptoms.
Hindsight is...
Yeah, no, but let's take advantage of it for a moment.
Yeah,
it's 2020.
Actually, if I had gotten these markers maybe in the beginning, if it was explained to me, this is what you're going to go through. This is how bad it's going to be. You're going to die. I mean... 3 to 5 years, but if it was more definite, I think that you would take it more seriously in the beginning.
So doctors are really afraid to hammer home, you're going to die. That is not a message that we're very comfortable, presenting to people, even when we're thinking it to ourselves. What are your thoughts about how doctors could communicate that effectively to somebody who was at your stage of the game earlier on? You said you were in denial, but how could doctors bring that home?
Possibly speaking to somebody like myself who's been through it, that knows the problems that you're going to go through. I mean, rather than just tell them you're going to die and it's going to be ugly, listening to I have a lot of knowledge that I could help somebody. I was telling Dr. Condos that in the waiting room when I go, I'm going every week.
Yeah.
There was this woman sitting in a chair with 2 oxygen bottles in the back. And I asked her, because I've become a lot more forward with it. And I went over and said, is she on the list? And the daughter said yes. And her head was down and she was having trouble breathing. And I put my hand on her arm and said, there is light at the end of the tunnel. And it's going to be great when you get that, you're going to be breathing again. And well, just to see her, she was so uplifted. And, and I think that if you had patients or people that have been through it before doing things like this, it'd be a great help.
I think that in chronic illnesses, we've learned a lot for providing support groups for other diseases, and I think this disease is one because it has this sort of, I'm a little short of breath, I should wear my oxygen, I should exercise, but I feel okay. The idea that it is progressive and that, people who've gone through it can share their experience with you.
So tell us about the transplant experience. You came to realize that you really needed the lung, the transplant.
Again, I'll relate that story. Be careful what you wish for. I was frightened to death of it. I went through the classes. They were talking about post-transplant and what can happen, the rejection. So I was really frightened to death of it. And even though I went through all the motions, I never thought I was going to get a transplant. And then we were at a wedding out in the Hamptons, and they called me at 2 o'clock in the morning. They said, be here in the morning. And they said, we might have a lung for you. We were there at 2 o'clock in the afternoon the next day. I was in the operating room by 4 o'clock. I was back in my bed at 11 o'clock. I could take a deep breath, no oxygen. It was wonderful. was a miracle. And here I am, running
There you
around,
are.
carrying on.
How long has it been since you got
6 months, April 16th was 6 months.
Mm-hmm.
So, yeah, you still get your good days, your bad days, but the good days, I say it's like the stock market. It goes up and down, but the
Gradually.
graft is going up. And I feel, I can definitely tell you the difference between.
I just want to bring you back to one other point. During your pre-transplant evaluation, remember when there was something about the liver function test?
Oh, yes, yeah.
Initially, we weren't a candidate because of the BMI, and then finally we got over that hurdle. We're a candidate now, we're going to get a lung transplant, and then there's something wrong with the liver.
Right. In the report, they said he's got a bumpy liver, could be cirrhosis. So that was a red flag at Columbia. And so I went to a specialist, and he said 99%, no problem, looks great. They said, then he put at the bottom, but cannot be 100% unless they have a biopsy. So Columbia saw that and said, got to go get a biopsy. So I finally got the biopsy, and they said, okay, everything's fine. So there it goes. That was the last hurdle. Mm-hmm. Actually, it wasn't. They wanted to do one more heart test. One more heart test. And then finally, now just hurry up and wait. And that was it. Hurry up and wait. I was on the 5 weeks, and I got a call.
That's what, yeah.
It was incredible. And the first time I went, I got the lung. I mean, as I say, I met somebody in the waiting, not in the waiting room, but I was in, they were talking on the phone. It was her 7th try. 7. And you go in there, you go down to the operating room, you're waiting, and the doctor has to sign off on it. 7 times she didn't.
What are the things that you need to be doing now that are challenging for you?
Just getting back into shape again. Once you, that month stay in the hospital, I mean, I just, and I lost I lost 15 pounds. I mean, I just put it back, but, and it was probably 15 pounds of muscle. Mm-hmm. So, I'm back in rehab again.
So back earlier on, you were hearing the doctors tell you, you need to do this, you need to do that, and you would nod very nicely, but
Exactly.
you'd be thinking to yourself, no, I ain't going to do that. Any of that going on now?
Yeah, you get lazy. I get lazy. And my wife will say, how you feeling? Well, I don't feel good today. Well, I wanted to sit in the chair. I just don't feel like getting up and going. But I can say this, is that there are days that I do not want to go to rehab. Mm-hmm. And but every time I get out of rehab, I feel terrific. Uh-huh. But getting there is just... you got to drag yourself in.
Can you do that?
Yeah.
Good.
Easier than I can. There's a gym across the street from us, and to get over to that gym is very difficult for me. To get to rehab, because there are people waiting for me, I wouldn't miss it.
If there were other people in Dr. Kondos's office who were part of your care, the receptionist, the pulmonary therapist, those were people who were waiting for you every time you came to the office. It was a team of people.
Yes, really. Okay. And it's really important. It is. But the one thing that you need to do, and no matter what, you need to manage your own health. You need to make sure that you get to the appointments, or don't wait on anybody to set up appointments for you. You just need to manage your own health, mm-hmm. and it's a full-time job.
And that was something that you learned to do.
I learned it from being there.
It wasn't there at the very beginning.
No, I wanted them to do it for me.
Uh-huh.
I wanted everything to be done for me. You should know that I'm sick, and that. So what do I do next?
Yeah.
So
you became much more active, engaged.
Well, I became more knowledgeable about it,
and you became part of the team in a different way.
Yes, exactly right. And
right.
You need to do that.
Yeah. And it's important for doctors and everybody else to sort of listen to what your experience is, so that they can help you grow into that.
Right.
Is there anything else about this experience, or you have an audience of physicians and potentially other patients as well? Anything in it that we haven't covered? Anything that you'd like to tell us, or thoughts that you have about this?
Well, we've covered a lot, and I've given you most of my experiences. There's no way to explain the dread that you feel when you finally come to the cognizant reality that you got problems. The dread is really, and I mean, I'm not so much, I don't know how to explain this, but the thought of dying didn't frighten me as much as the thought of once you cross the line, you can't come back.
Mm-hmm.
That was terrifying to me. And
it was the irreversible progression.
like once you close your eyes, you're not coming back. Once you die, that's it. It's over. And it was getting to that point. I don't know how to explain it to you, but it was just real dread, and it weighs on you all the time.
And what can be the most helpful things to hear when you're having that realization?
You're going to get a transplant. It's going to be okay.
Okay.
It's the only thing that you got to hang on. So when I had that problem with the liver and that setback, that was devastating.
Mm-hmm.
And I hope it's okay. I hope it's okay, because if they said to me that's the end of it, you just don't have anything to hang your hat on. So it's really important that you got that one thing, that one guiding star, that one piece of light that you got to hang on to. Otherwise, it just gets ugly. So I'm here because this lovely person here saved my life.
So I'm wondering, now that you know what pulmonary fibrosis is, how would you explain what happens in the tissues of the lungs? I'm thinking about different kinds of textiles, some that are thin, that air and stuff passes through, others that are thick. Can you put together a metaphor for us?
Yeah, actually, I would be thinking of it like a brocade.
Okay.
Where the background is sheer, and then you have the overlay on it.
Okay.
And that would be my take until the whole fabric, there is no more sheer anymore. It's all brocade.
So the brocade is the fibrosis,
where the
air sacs.
the air sacs is the sheer,
right.
And then the embroidery is the scarring.
If somebody had presented that image to you before you had the experience of the shortness of breath, and described the brocade as sort of
that eventually all the sheer was going to be taken,
was going to be covered
right.
by the embroidery and by the brocade.
Right. Well, that'd be terrifying.
Would it?
Yes.
Would the imagery have been terrifying enough to change your motivational state? I know it's hard to go back there, but
yeah, I don't know if anything would have changed my mind until that first time where I couldn't take the breath.
I want to thank you both so much for sharing your experience. This has been amazing, and I think you've shared insights that are rarely spoken out loud and that people need to hear, and it's going to be extremely valuable.